Beautiful. Good morning, everybody, on this 25th of January 2023. And thank you very much for joining us for Meet the Specialist. These little sessions came about because we have more and more people asking when they make a booking, but what is she like? How does he come across? And so we can now do these short little introductions and direct our clients to our YouTube channel to have a quick look. It's like a video CV. Now, the first one for the year, we are absolutely honoured to have the wonderful nurse Catherine Sharp with us. Catherine, I'm just reading from notes here because I can't possibly memorise this all. So Catherine is currently a PhD candidate at Flinders University. She has a Masters of Health Law, a Masters of Public Health, a Masters of Clinical Nursing, a Graduate Diploma of Clinical Nursing, Nursing Certificate, Cardiac Nursing, Diploma of Psychotherapy and Counselling, Intensive Care Certificate, General and Paediatric Nursing Training, and she is a lawyer, which makes her an absolute double weapon in the personal injury medical negligence space. We are seeing more and more reliance on nurse testimony and nurse assessments and reports in this space, and they are being critical in the quantum of a matter and really getting down to brass tacks as to what went wrong, because nurses are the ones who see exactly what happens at the bedside and they see the pathways. What should this symptom have triggered the nurses or practitioners to do? What should this presentation have resulted in? What consultation should have happened at that point? And they're the ones who can really get to the crux of your negligence. If I can ask if you can all keep yourselves muted until the end of the short presentation, and then you're more than welcome to ask any questions. This will be a short session, but just a really great way to get to know our wonderful specialists. So I'd like to hand over to you now, and thank you for your time, Catherine Sharp.
Thank you so much for inviting me to speak. It's wonderful. For everybody, I'm a registered nurse and I trained in the UK in the 1960s. And for anyone who's old enough, you will know that that was the day, they were the days when we didn't have any university. We trained at the bedside, which is, to me, I wish it was like that again. It was just wonderful. So I'm trained in general nursing and in pediatrics. And then I came to Australia as a 10-pound POM, 10-pound migrant. And I traveled around for 2 years, working in different hospitals as I was running out of money. So just going back, so for decades now I've been nursing, but I now am a full-time medico-legal writer. I don't do any clinical work, although I miss it, and whether I'll go back or not, I don't know. So I've worked in hospitals, the community, and a lot of aged care. I've been in possibly 200 residential aged care facilities in Sydney as a wound care consultant. So that's one of my private businesses in wound care. And I see a lot of patients with pressure ulcers. They're absolutely awful. The thing about them is that they're foreseeable and they are preventable. And I'm doing lots of cases on patients who develop pressure ulcers, whether in hospital or aged care facilities. He walks into hospital for elective pressure ulcer and end up having a below-knee amputation. This is unacceptable. It's unacceptable because they're foreseeable and because they're preventable. And now more and more people are suing the healthcare system. And these things happen in our major hospitals. And you would think that they'd know better, but clearly they don't. I do have quite a few peer-reviewed publications on pressure ulcers, and as they often do. Some of the other
Catherine, my love.
Common cases
Oh, Catherine, you've been freezing again a little bit. Pardon me, I'm so sorry. The joys of the internet. Could I ask if you pop off your video, but keep your audio on, obviously, so we don't miss a word.
Okay, am I just pressing stop the video?
Stop video, yep. That way it makes the internet easier and the sound is less likely to cut out.
Stop video. Okay,
Beautiful.
it stopped. All right.
Thank you.
And you can see there I'm known as Kate. So a bit like the princess, Chris and Catherine called Kate. Extravasation of fluids into arms is a huge problem, and I've done many, many cases where nurses have inserted a cannula into a vein in the wrist, where you should never put cannulas, or nurses should not put cannulas into veins in the wrist. The anatomy of the wrist is extremely complex, but they will stick a needle in there and then start running, for example, iron or chemotherapy drugs into the vein, and they've strapped the or an IMED, that's a machine that pushes the fluids through. Say there's a blockage in the vein, the machine will alarm, but nurses are renowned for just pressing the reset button. They start all over again, they don't check the site. And these things, iron and chemotherapy drugs, do infiltrate the tissues of the arm and tissues. The chemotherapy cases like that, iron will stain, and it's a permanent brown stain of the arm forevermore. I do quite a lot of injured nurses, so nurses' compensation claims where they've been asked to do something with a patient that they're really not supposed to be doing on their own, and they get injured by the patient, or they suffer severe back injuries from lifting and turning, which they're not supposed to do on their own. And every manager of every healthcare facility would or should know this. And these nurses, many of them go for surgery on their backs, but they never work again. And I've heard that facilities are very reluctant to pay compensation claims. Another common problem, and it's so common, it's just scary, patients who fall, and often this is the frail aged, who are known to be at risk of falling. They may have a bit of dementia, they'll be on lots of drugs that may alter their conscious state, but they slip and fall, they land on their heads, they break arms, they break legs, and they die. There's lots of falls and fractures, falls, fractures, and deaths. But any standard of nursing care case that you have that you would like me to consider, please contact Michelle or contact me. I'm not contracted with any company anywhere, but I do cases for different third-party companies. So I report on the standard of care. As a registered nurse, I'm qualified to comment on the standard of nursing care. I'm not qualified to comment on the standard of medical care, but for example, if I see something in the notes that I think might have been caused by a doctor or a physiotherapist or an OT, I will just call the lawyer and suggest that they get a specialist in that field to comment, because I can't comment on a standard of medical care.
That's actually really good, Catherine. One of the problems we continually have is specialists who do comment on things outside of their expertise. And every so often, a specialist who might tender a report and then might say to me casually, Oh, I wish they had have also got a hematologist, because honestly, some of the stuff I saw in that blood work, and I'm like, hey, buddy, you
You
should
have
have
to
told
say,
me, and I would have called the lawyer and told them.
yes,
And of course, I
absolutely.
then do. But yeah, I love it. That's the thinking of a nurse, to be that proactive and that organised.
Well, I've actually had a couple of reports where doctors have commented on my comments on nursing care, and they cannot possibly, we're not allowed to comment on other specialists' roles.
No, of course. So that's actually been really interesting, and it's opened up the sheer breadth of what a nurse can comment on and contribute to in this space. Does anyone who's listening here have any questions that they would like to ask of Catherine? You can unmute yourself and do so. No questions. I do have a question for you, Kate. I wanted to know, would you be able to just give a brief overview of a matter where you were asked to comment on the standard of nursing care, but what you actually found was not even what the lawyers had have thought, but it was something that really turned a matter around, something that was really quite unusual?
Yes, and this happens from time to time. For example, lawyers can't always read the notes, or they don't always understand what the terminology is. So I remember a lawyer asked me once, what does SOB mean? And I said, oh, short of breath. Well, what does SOOB mean? I said, sitting out of bed. So they have that, they're trying to understand the terminology, but unless you do, you can head off in the wrong direction, I think.
Yeah, absolutely. And of course, short of breath would indicate that certain pathways should have been followed, or that
Yes.
perhaps a respiratory consult or a blood oxygen check should have been ordered.
There are other post-operative cases.
Yeah.
Know how to record blood pressure, pulse, temperature, and whether the doctors actually check the charts. Often they don't have time. They're relying on a nurse to report to them that this patient's blood pressure has gone from 120 on 80 to 100 on 70 to 90 on 40. Nurses don't report it until it becomes a MET call, when the patient has had a cardiac arrest. But that's way too late. Nurses would or should know these very, very basic observations of temperature, blood pressure, pulse, urine output. If they've got intravenous fluids going in, they should have a urine output.
Right.
If they don't have a urine output, it should be reported.
Yes. But how much of nurses not reporting, which goes to the negligence of the hospital, I guess, but how much of a nurse not reporting is because they can't find a specialist to report it to, or they're afraid of the doctor to report it to? How much do you find that that's ever a factor?
I've certainly done cases where nurses have been terrified of the surgeon, but they've gone to a senior nursing member of the staff, and even all the way up to the director of nursing. Nothing is done because this the surgeon is such a bully. And these have come out in cases from time to time. But I would have to just encourage nurses. They've got a responsibility. They have their own code of ethics, code of conduct, standards of care. That's what we base our practice on. This is the foundation of nursing practice. And they would or should know, or they can actually phone another doctor. If there's a friendly doctor on site, I would encourage nurses to talk to that person. But initially they can go to their upline nursing manager and report what they think is happening.
Wow. So there's really no excuse.
No.
Well, thank you for those of you who've joined us, and this video will be available on our YouTube channel, and we'll be encouraging anyone who inquires about Kate's work to have a quick look at that to see just how wonderful she is. Pop your face back on again, please, you lovely lady. Thank you again. Thank you very much on behalf of MAG. Oh, and we're getting some thank yous in the chat there. Thank you so much, everybody. Go and have a great rest of the day.
Thanks.
Let's end that recording.